Thank you very much for your kind introduction. I'd really like to highlight some of the research we've done over the last 6 to 9 months, particularly in the context of COVID, because I think it shows you very much why networking in cancer research is so important, and also the absolute vital importance of data. These are my disclosures. COVID-19 for me is personal. On the 29th of March of this year, my uncle unfortunately died of a COVID-related disease. One of my colleagues, Edward Vidoliak from Split in Croatia, while reaching out to me to sympathize with me for my loss, also made the following statement, which really worried me. He said, people are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. That really worried me, because also in the UK, I had heard similar anecdotal stories. But where was the evidence? So this prompted us to develop a data-driven collaboration between DataCan, which is the UK's health data research hub for cancer, and University College London. It involved 2 parts: accessing real-time data from trusts across the United Kingdom, and then also modeling excess deaths due to the adverse impacts of the COVID-19 pandemic. But first of all, I'd like to tell you a little bit about DataCan, the UK's health data research hub for cancer. The idea for health data research hubs came out of the life sciences industry strategy. And this was funded as part of the Industrial Strategy Challenge Fund in the United Kingdom. Health Data Research UK, which is the national institute for health data research across the 4 nations of the United Kingdom, delivered this program. And the program was launched in October 2019. So we're just a little over a year old. This slide here really shows you this idea we had of bringing together all of the data in relation to health in the United Kingdom in order that we can develop discoveries that will actually improve people's lives. If you just see here on the left-hand side of this slide, what we see is the different data custodians. In the center, the Health Data Research Hub, that engine that's really driving health data research. And then on the right-hand side, we have a gateway. And this is where we put metadata that actually tells people what are the data sets that there is potential for people to work with to look at developing new innovative diagnostics, for example, or new treatments for diseases such as cancer. And all of this is very much put under a trustworthy use of data prism and very much involves significant patient and public involvement. There are 12 health data research hubs in total across the United Kingdom. We're DataCan, the health data research hub for cancer. But as you can see, there are also hubs for respiratory health, inflammatory bowel disease, eye disease, and cardiovascular disease in terms of different disease entities, but also thematic hubs, for example, for real-world evidence, clinical trials, and acute care. This is being a game changer in the United Kingdom. What we are trying to do is to deliver what patients expect in relation to the use of their data, but also what the National Health Service, for academia, and for industry data users want. So we want data that's longitudinal and multimodal, easy to access through a single portal, high quality, preferably with UK-wide coverage, fast response times. We don't want to have data that it takes a long time to access. Expertise, particularly in artificial intelligence and accelerated analytics, and that it can be used for multiple different purposes, including our response to COVID-19. And as I said, all of this is underpinned with a building, but also critically a maintaining of citizens' trust in how we use the data. Patients in DataCan are at the heart of what we do. They're involved in decision-making at all levels of DataCan. We have 2 patient advocates on our steering board, patients on our management group, and involved in specific projects. And I've just indicated some of the different areas that they've been involved in to date in the first year of DataCan. This is Jackie Gaff, a cancer survivor and one of our PPIE members of DataCan. And you see what she says here. Patients want their data to be used to improve care. In fact, they're often surprised if it's not used already. So if we go back then to how we responded to the COVID-19 pandemic, we did 2 things. First of all, we looked at accessing and analyzing data from hospital trusts across the United Kingdom. We deliberately chose two measures which we can easily collect to determine the effect of the pandemic on cancer. The first were 2-week waiting times, which are also sometimes called red flag referrals or urgent referrals. And these are really early warning systems for the suspicion of cancer. So this is looking at the diagnostic pathway, if you like. And then the second data that we looked at was in relation to chemotherapy attendances. And this is really a proxy measure of the health of the cancer treatment service. So diagnostic pathway and treatment pathway were the two things we look at. This is just showing you some of the data that we collected from different hospitals across the United Kingdom. On the left-hand side is the 2-week wait or urgent referral data. On the right-hand side, the chemotherapy attendance data. And you can see in the areas that are shaded in green, red, and yellow and pink, you can see there what happened during the pandemic. So you can see a very precipitous drop in relation to both 2-week wait and chemotherapy attendances. And then you also see the start of a recovery. The data showed us some very worrying trends. First of all, 71%, so 7 out of 10 people with a suspicion of cancer were not getting referred on to cancer specialist services. And in relation to chemotherapy attendances, 4 out of 10 patients were not getting access to their chemotherapy at the appropriate time. This was the first data that drew attention to our government, to academia, to the National Health Service and the public, to the disastrous impact that COVID-19 was having on cancer services and therefore on cancer patients. Why do we need real-time data? Because one of the things we emphasized in this was weekly data, so we collected it every week from the different hospital trusts around the United Kingdom, and it came back to us in near real time. Well, this is the reason here. What I'm showing you on the left-hand side is the overall English 2-week wait data that's available nationally. And we looked at this at a particular moment in time on the 9th of June 2020. As you can see from the plot, it really is fairly level, little bit of variation, but overall fairly level, and doesn't really show any impact of the COVID-19 pandemic. The reason for this is because this data, as you can see in the circle, is from March 2020. So it's over 3 months old. So therefore, that's why you're not seeing any effect, because it's actually showing you what's happening before the pandemic, not during the pandemic. If you contrast that with our own data, again looked at on the 9th of June, but what you can see is this data is only 4 days old. Because of our real-time network, we've been able to collect data in real time and report it back and use it to influence how we do policy, how we change things in relation to COVID-19 and cancer. So it captures not only the precipitous drop in urgent cancer referrals that you can see there, but also the start of recovery of the urgent diagnostic pathway. And it also shows us we've really had an avalanche of missing diagnoses. So this is why we need real-time data, and we are now setting up a real-time data network right across the United Kingdom. Unfortunately, the disruptions to cancer services have actually happened right across the cancer pathway due to COVID-19. You can see here in relation to presentational delay, so in relation to screening essentially stopped, referrals were significantly down. You can see then when we look at the diagnostic pathway, CT scans, MRI, and particularly colonoscopy really plummeted. And you can also see the effect on treatment in relation to chemotherapy, radiotherapy, and surgical interventions. Also, significant disruptions in cancer research. Overall, 30% of clinical trials in cancer disrupted, but in some centers as high as 80%. And also an impact on discovery research because a lot of laboratories shut down, and also translational research. The second thing then we looked at was looking at what was the effect of the COVID pandemic on excess mortality in people with cancer. We looked at nearly 4 million citizens' data through a primary and secondary care linked data set. We modeled different scenarios to determine excess deaths that would be due either directly or indirectly to the pandemic. And we used that real-time data that I just showed you to inform this model. And what we saw was again worrying, looking at different scenarios, but the most robust scenario showed that we would see between 7,000 and 18,000 excess deaths in people with cancer. So a very worrying statistic. We also looked at the potential impact of comorbidities, and we saw that there was an additional risk of excess death if you had at least one additional underlying health condition or comorbidity. And the four main ones that we saw, or the five main ones that we saw, were cardiovascular disease, hypertension, obesity, diabetes, and COPD. A number of these we can actually intervene in, but obviously these services were also affected by the COVID-19 pandemic. If we just look locally in Northern Ireland, where I am from, you can see here, and this is very detailed data going in around the time of the pandemic. You can see a significant drop when you compare it with data from 2016 up to 2019 with 2020 figures, over 30%. But also you can see differences in different cancers. So lung cancer very badly affected, prostate cancer very badly affected compared with, say, breast, ovarian or bowel cancer intermediately affected. What's been really worrying is we feel that we're now taking a step backwards after all the hard work we've done over the last decade in terms of improving cancer outcomes. If you look at the 5-year survival that's anticipated for 2020 in the context of COVID, and you allow for 3 months, say, of disruption, which actually may be conservative, if we see stage shift in the detection of cancer, i.e. cancer being detected later rather than earlier, we feel this can significantly affect 5-year survival. And you can see some of the modeling we've done here. We'll set back lung cancer in terms of 5-year survival of 2 or 3 years, breast cancer 7 or 8 years, colon cancer, colorectal cancer, nearly a decade. So we're really worried about the potential long-term impact in relation to the COVID-19 pandemic on patients with cancer. So we shared these results pre-submission, so before we submitted them to a journal, with government and NHS stakeholders. That included the 4 chief medical officers, the National Cancer Director, and the Emergency Committee in relation to strategically advising the government. Our data contributed to the decision to start restoring cancer services. We also, working with the Association of British Pharmaceutical Industries, they highlighted that we should be supported to help improve and maintain the standards of care in cancer. Significant interest in the research community, a lot of interest in the media, as you can see, both in relation to the print media and TV, for example, Panorama, and also we were quoted in a recent report extensively by Carnal Farrer and the Institute for Public Policy Research. So this data really has hit a chord and has showed the challenge that we face in relation to patients with cancer. But also data can help us in supporting the recovery. I already indicated the challenges we're seeing in colorectal cancer in relation to presentational delay, in relation to screening, for example, both diagnosis and also treatment, and having to treat patients at a later stage of their disease. Our work, and this has been led by Claire Turnbull in the Royal Marsden, has shown that prioritization, using, for example, the fecal immunochemical test, or FIT, can avoid nearly 90% of the excess deaths that we predict in relation to colorectal cancer, and also reduce requirement for colonoscopy by over 80%. So what we're showing here is that using data, it can help us support both the health system by prioritizing the use of tests, so therefore making sure it's actually prioritized for those who most require them. And that obviously has an effect in relation to solving some of the capacity problems, but more importantly, patients. So to ensure that their presentational diagnostic delays are reduced. It is only a short-term solution. We really need to see sufficient colonoscopy capacity long-term, but it just shows you what you can do with data. Are we getting back to pre-COVID-19 levels? This is just showing you the 2-week wait or urgent referrals, the total data. What you can see is we're starting to get back to near 100% again, but there's a huge gap, all those misdiagnoses in the middle. If we look, for example, at lung cancer, we haven't got back to 100%. We're only at about 60 or 70%. And similarly, if we look at some other diseases, so here we show the worst is in relation to lung, 67, and then urology, so prostate cancer, lower GI, and breast cancer are better. But we're still missing that huge gap in the center in relation to all those misdiagnoses, that avalanche of misdiagnoses that I mentioned earlier on. From an international viewpoint, we presented our data to the European Cancer Organization, who's Europe's largest multidisciplinary organization. A lot of interest in the data, anecdotally similar situations in other countries in the EU and in Europe. And I was invited to co-lead a European Cancer Organization's special network on COVID-19. Researchers in other countries are also following our approach in analyzing near real-time data. I'm delighted to say that on the 18th of November, we launched a 7-point plan for COVID-19 and cancer at the opening session of the European Cancer Organization Summit. And it received incredible interest, a lot of impact, a lot of people taking on board what we are saying. This is the 7-point plan, which we say will build back better. We need to urgently address the cancer backlog. I would suggest getting back to 100% is not enough. We need to get to approximately 130% of our services in order to address that backlog. We must restore the confidence of European citizens and patients in cancer health systems. We have to encourage people to go to their general practitioner if they have a suspicion, symptoms of cancer. We need to encourage cancer patients to continue with their treatment, even if they are worried about the potential effects. So we need to restore and maintain that confidence. We also need to tackle both the medicine shortages, the PPIE shortages, the equipment shortages, and also the gaps in relation to the cancer workforce right across the European continent. The other thing is we need to use innovative technologies and solutions that both strengthen cancer systems, but more importantly, provide optimal care to cancer patients. Data is crucial to all of this. You have to embed data collection, have to have rapid deployment of cancer intelligence so that we can actually enhance policy delivery, we can enhance service delivery for our patients. And we really need to move away from the maxim that health is a single country competency in Europe, that each country deals with its own health situations. We must have a Europe-wide health cooperation as a key learning from this crisis. So as I said, getting back to pre-COVID-19 levels, it's just not enough. We've shown, both in the research on excess deaths and on the significant perturbations of cancer care that the real-time data analysis has shown, that there are big challenges in relation to cancer services in the United Kingdom. But the government has listened to us. The 31st of July, a phase 3 letter from Simon Stevens, who's the CEO of the NHS, said that cancer was the first priority for recovery. Our work highlights why unlocking the power of data is absolutely critical. And it's really important that we use weekly, near real-time data. So what I would exhort you to is to follow the science, but most importantly, to follow that data. Getting back to COVID-19, pre-COVID-19 levels is simply not enough. The new normal can't be the same as the old normal. And what I'd like to end with is the following. Data is the new oil, so let it flow. Otherwise, you're making me and my colleagues and everybody in this audience who's interested for cancer patients in fighting cancer and COVID-19 with one hand tied behind my back. Thank you very much for your attention. I'm very happy to take any questions.